So this is the Increasing Value in HIE in Colorado panel, and I'm incredibly honored to be joined on stage with my esteemed colleagues. I thought we'd just kick off with letting you guys give a little introduction about yourself, where you work, what you do in your organization, your background with Contexture. So Brian, you want to kick us off?
Sure. So I'm Brian Turner. I'm the CEO for Solvista Health. We are a community mental health center, a licensed substance abuse treatment provider, and an integrated primary care provider. We serve 4 counties, the upper Arkansas River Valley, so rural frontier counties, about 4,000 square miles that we cover, and we've got 9 locations across those 4 counties. Probably worth mentioning, just because I heard Morgan mention it and Commissioner Medlock this morning, we're also a behavioral health crisis provider. So we do 24/7, 365 mobile crisis services. We just opened a new crisis stabilization facility in Salida, Colorado that has acute treatment, 24/7 walk-in crisis services, and withdrawal management services. And so I think that's a really important piece and part of the reason that this conversation is a really important one for Solvista Health. Prior to going to Solvista Health about 4.5 years ago, I spent 10 years or so in Denver working primarily in behavioral health policy. It's where I first met Morgan and a lot of the co-Rio folks working on things like health information exchange for behavioral health. I would say it would be easy to assume that after 15 years in community behavioral health that I would identify as a behavioral health guy. I really don't. I think of myself much more as a public health guy. And more than anything, really driven by just this belief that if we do a better job at integrating and collaborating and aligning all of our efforts collectively, that's really the best path towards achieving better public health and better health outcomes. And so in that vein, over the 10 years that I spent with Colorado Behavioral Healthcare Council, which is the association for all the state's mental health centers, at the time all of the state's Medicaid behavioral health managed care entities, crisis service organizations, managed service organizations on the substance use side. Just spent a lot of time working on, and I'm seeing familiar faces already in the crowd, just interoperability grants, the state innovation model, practice transformation efforts, the governor's behavioral health task force, trying to overhaul and reform and constantly improve healthcare. And so in that vein, and really thinking in public health, I think the importance with everything, kind of my underlying driver and main motivation for trying to infiltrate Contexture, is that we need to be better aligned. We need to integrate, and we need to have better collaboration at local, state, national, and I think as the pandemic indicated, even global level. So that's a little bit about why I'm here, and excited to talk a little bit more about all that.
You're really cool, Brian.
Hey, thank you.
Good morning, everybody. I'm Darlene Taddy. I'm a physician, a hospital medicine specialist, I practice at the University of Colorado Hospital. I'm a faculty member, an associate professor at the University of Colorado School of Medicine, where I've been since 2010. I'm also now the Associate Chief Medical Officer for Patient Flow at the University of Colorado Hospital, and work in a system with UCHealth, which is 12, almost 13 hospitals soon. We have clinics, of course, across this state. Lots of presence in emergency medicine, primary care, of course, multi-specialties, hospitals also. So like I said, we have about a dozen hospitals. And so a lot of my role now is looking at how patients are moving and receiving care throughout our locations, and ensuring that they have access to the care that they need at the time that they need it. My interactions with the Health Information Exchange have been one, as a provider, I have been able to utilize the information contained in the HIE to provide better care, more efficient care, reducing redundancies of workup, ensuring that I'm preventing medication interactions, for example, by having the information that's contained within the HIE on those patients. I live in Colorado, so I'm a patient. I suspect that there's a record in the HIE about my health and the care that I have received in our state. And then as the ACMO for patient flow at my system, I certainly have a sense of where patients are going, not just within my system, but also outside of my system. In my prior role as the Vice President of Clinical Affairs at the hospital, at the Colorado Hospital Association, I was previously a board member, so appreciate that previous engagement as well with the HIE. So glad to see it where it is today, and looking forward to this discussion.
Hi, Paula Kautzmann. I'm the Chief Information Officer for Colorado Access. Colorado Access is a regional accountable entity, or a RAE, in 5 counties, including Denver County. We cover over 600,000 lives right now. As the RAE, we're responsible for ensuring that Medicaid members receive the medical and non-medical care and support services that they need to ensure that they can lead as healthy lives as they can. I've been at Colorado Access for 4 years. Prior to coming to Colorado, I was in the Upper Peninsula of Michigan for 20 years. I worked for Upper Peninsula Health Plan. And in addition to Medicaid, Medicare, and dual eligible services, I also set up a health information exchange. It was a small regional health information exchange for about 50,000 members in the Upper Peninsula of Michigan called HIE. We also were the first world pilot for health leads for a social determinants of health exchange platform. And so that is still going today in the Upper Peninsula of Michigan. So I'm very proud of that. Coming to Colorado, obviously got engaged immediately with then Creo, now Contexture. Huge supporter of health information exchange. Obviously from a health plan perspective, claims data is good, but the HIE data kind of rounds that out and gives you that real-time information that we need to better support our members. So thank you.
Fantastic. Well, thank you for allowing me to share the stage with you this morning. So we've got an accountable, regional accountable entity, a behavioral health organization, and a hospital here sitting on the stage. And I'm sure that this is going to be a lively and interesting conversation. So I fully expect you to, build off of each other, debate one another, whatever you see fit. Just a note for the room, I recognize it's about 45 degrees in here. They are working on bringing up the temperature, so if you are shivering in your seat, we're trying to get that taken care of. So my first question is, you saw a little bit about the current state of affairs with Contexture and some of the innovative things that we're doing. From your seat in the theater or where you sit in the landscape, where do you see us going from here, and what should we be focused on moving into the future?
I'm immediately next to you, so I assume I go first. Yeah, I think of all the things that you talked about, the one that I have long been most excited to see come to fruition is meaningful behavioral health information exchange. You mentioned that conversation has been happening for a decade. It is no joke been happening for a decade. And the technology is there. I honestly think the policy and the legal opinions necessary are there to do something more meaningful, where we are not only as a behavioral health organization able to be receiving really critical information about the people that we're serving, but being able to push really meaningful data into that same system so that people throughout the healthcare ecosystem can have a better sense of what that patient's needs are, what that individual's needs are, and how we can meet them. When you go the next step and start to talk about social determinants of health, that is the most integral thing as a behavioral health organization that we have been doing over the last several years to try to expand our reach. And so if we can combine both that kind of medical, physical health information with behavioral health information, with the rest of what happens outside of our 4 clinical walls, that to me becomes incredibly powerful, really game-changing data for us to make a difference. We have, especially in rural Colorado, a lot of people who pass on through, right? Either they are coming to enjoy the Arkansas River and kind of see us as a destination, a place for a vacation, or there's just in general a lot of transients, people kind of moving through and then moving to even within our 4 counties, but also then to our adjacent counties. If we can have a better way of tracking who they are engaged with, what systems they are being served by, and then we can actually be collaborating, referring, closing those referral loops to improve treatment. That is going to be really powerful. You mentioned we get to debate people. I don't know if we're going to get in a debate, but we are. I'm also the president of Ray Region 4, so I see you as direct competition in that space. So I don't know what we're going to debate about, but if it's which is if it's which is the best Ray, I'm going to put my stake in the ground now. But that's also really important, right? All of Southern Colorado, we've got individuals who have assigned primary care medical providers. They don't necessarily have assigned anything else, and they may not even know who they are assigned to and who they're not. And so the better data we have to make really informed decision making, not only is that producing better health outcomes, but as a Ray who's at risk on the behavioral health side of the Medicaid business, there's a direct imperative to be finding ways to control costs, find ways to prevent the hospitalizations that are avoidable, readmissions into emergency room, finding the appropriate level of care, and all of the other things that happen, again, outside of clinical walls that can contribute to a better health outcome for somebody. So long-winded response, and really just a long roundabout way to jab at Colorado Access.
All right, you pitched it over the wall. I'm going to come at it from a different perspective, really thinking about, from an IT perspective, how do I take all of the words and create defined user stories to be able to really dial into the specifics of how we do those things. So, SDOH is long been one of my passions, but I think depending on who you talk to, there's all kinds of different ways to look at it. There's the care coordination aspect of social determinants of health. There's the community organization and sort of, all the services that a person might get. That's been lumped into SDOH, as well as traditional, housing, food, the CBO type services. So you almost have to separate those things out and get really specific about what you're trying to do and how you're trying to manage that if you want to develop some kind of structure to be able to share that data and do something meaningful with it, whether you're building alerts or you're closing the loop on the referral you might make to a person going to a CBO. Did they get their needs met? How did that CBO do? How do we start to measure those organizations that are doing the good work and ensuring that members who aren't interacting maybe with the medical system and getting the screening that we can share, then as a Ray, we can reach out to those members that aren't engaging with their provider, start to work with our care management department, our care coordinators, and start building that trust around whatever they need from a social needs perspective, and then start to work with them on moving them into sort of, the primary care services and other services that they might need.
So this is going to be a really interesting conversation because Colorado Access serving very urban areas in the Denver metro area, Southern Colorado, of course, serving a huge swath of geography with probably more cows than people is the way I used to describe Eastern Colorado. It'd be really interesting to hear about some of the challenges that you guys are facing in your different geographies and how you're meeting some of those. But Dr. Tadley, as we think about where we go from here, what's high on your list?
The patient, of course. And to me, there's so much health-related or health-influencing or health-impactful data out there that I would love to have access to for every patient. But that volume gives rise to information overload. As a direct provider, or even as somebody who's in a physician leadership role at a system and a hospital level, there's so much data that I don't know which of those pieces of information are really going to be actionable. Help me understand what I need to do today for the patient that's sitting in front of me. That's the kind of ask that I would have as we look ahead to the future and really making our HIE more of an exchange, more functional. Melissa talked this morning about the bidirectionality of it, being able to have a conversation, not just see this and look at a whole ton of data and then think, okay, how am I going to sift through this? Mm-hmm. So from that perspective, I would say that the social determinants of health data, the behavioral health data, which oftentimes is invisible or difficult to get to, really tells me about who is the person in front of me and what do I need to do to meet that person where he or she or may be at this moment so that I can provide the best care in real time for that patient. I think easing access to that data and to the insights that I would need to really take action immediately, that would also be high on my list of asks. But they've already mentioned the key things that I would want to have the comprehensive picture, the whole person picture of every person that walks into my walls.
Yeah, I think that that's really
Doors.
critical. Don't walk into
Walks
the
in
walls.
through the doors, in the walls of my hospital.
I mean, I think that that's really critical, regardless of the setting.
Yeah.
You know, one of the challenges, but the benefit of having 10 years behind us of building this network is we have this enormous amount of data, and we are getting to the point now where it's too much information. We have to whittle it down to understand what's really important to Dr. Taddy during this visit. And, you know, just to build on Dr. Medlock's comments this morning, you know, when we're talking about disenfranchised populations, people who are going through, you know, significant challenges, having to retell that story every time just continues, you know, to build on that, on the trauma that they may be experiencing. So, well, thank you. And again, feel free to continue to debate about who's the number one, Ray. So as you think about the things that you all are involved with today, what are kind of the one or two top challenges that you're facing today, and what are some of the solutions that you're looking for, maybe from a technology, maybe not, to address those challenges? Let's go in reverse order.
Oh, geez. Okay. I was going to kind of wait. Well, I think, you know, we talked about the social determinants of health exchange with the hospital transformation program that you had, you know, highlighted. HTP, there is a requirement for facilities to share the screening data with the RAE. And so as I'm getting that data in, we obviously have to do something with that. So how do we take that information in, and how do we build programs that I can give an actionable alert to someone to do something? I don't just want to send data to somebody that they don't know what to do with, because you're going to get information overload pretty quickly. But I think that's probably our number one challenge that we're working through right now. You know, you kind of mentioned the urban versus rural. With respect to data in general, in Denver County, there are so many parties. There's so much going on. I think everybody has initiatives, and so how do we as a RAE take all of the initiatives of all of our providers? How do we support them in what they're doing? And then how do we make sense of all that? So I think that's one challenge, especially in Denver County. And the other 4 counties, I think each community is different. So really meeting each community where they're at in each of the regions, and they're almost like mini, you know, urbanized communities throughout all of our counties. And so I think getting our arms around the HIE data that we get right now, we get the so-called fire hose of real-time information. How do I take that fire hose, put that in my warehouse so I can do retrospective analysis, and then how do I build high-value alerts that are actionable, as Dr. Taddy mentioned, so somebody can do something with it. So I think our challenge is how do we take all this information and, again, you know, build those user stories, and then how do we monitor that and figure out where we're being successful? So I think there's a lot in the data analysis that you talked about. I think there's a stronger partnership we definitely could have with Contexture with respect to our data and some of the dashboarding and helping us find some hot spots and really drill down. So I think there's so much opportunity, it's almost tough to figure out where to start.
Mm-hmm.
Yeah, I'll just second that there is a fire hose of data, and it's not just the data that's been collected, but I would say that there are so many technology inputs now where we could be gathering data from individuals that's also contributing to the amount of the overall volume of data. But there's also a very dynamic environment. So our communities, they're very diverse, but they're also changing, it seems, every other week. The growth of the population in our state has brought in very different types of people, different types of population. How do we keep the data that's in our HIE as up to date to the minute hour, but to the minute as possible, since we are now able to get data in real time about somebody's heart rate, their blood pressure, how they're feeling, their mood, I mean, and I think that degree or pace of change makes it very difficult to keep tabs on individuals and how they're changing. And so I think that challenge of knowing, is this person still living at this address? Is this person still benefiting from these benefits or still receiving these resources? That could be different in 3 weeks, much less 3 months or even 3 years. And so the information doesn't have to just be analyzed and surfaced up in a way that's digestible, but it also has to be immediate, recent, up-to-date, accurate. So that, I think, to me, is one of the biggest challenges, which relates to another big challenge that I think really impacted the healthcare industry, which is how do we have our patients and our communities trust that the data is accurate and truthful about them, and that they can then also verify, yes, that is me, and that data will actually build their trust in us as a healthcare system. So those are the two challenges I think we face.
So I would agree that there's definitely information overload, but the struggle that we have in particular in our rural part of the state is that we still have really critical partners in our healthcare system that aren't participating with CoRIO or Contexture, right? So we've got 2 of our major regional hospitals that just don't use it. And we interact with them constantly. It takes a ton of manual effort to try to understand what's happened with an individual when they come into contact with our behavioral health organization. And I'm just incredibly proud and happy to hear of the Forever Free program, right? Like, there can be a direct incentive and no fees to participate with health information exchange as a critical access hospital. And even still, I think your sales team is going to have their work cut out for them, because there are concerns. Hey, this is one more thing we got to do, one more thing we've got to maintain. And the value proposition is not fully understood yet, but I definitely believe that it will be. So even though there's some level of incomplete data, there is still information overload. So I very much agree with that. One of the I don't know if it's possible or what the solution necessarily looks like, but when I think about what might be possible in the role of Contexture and just thinking about technological solutions to difficult problems, also building on what Commissioner Medlock said this morning, we've got an unbelievable amount of fragmentation in the system right now. We have behavioral health, which is funded through Medicaid as the biggest payer of kind of community behavioral health services. We have the newly formed Behavioral Health Administration kind of overseeing a lot of things non-Medicaid, but we still have regulation and funding and data delivery and reports and outcomes due to probably 5 other major state agencies as a community mental health center. That data tends to be one direction. We feed it up to the state. We have no idea what it means. We don't necessarily see that as a way of understanding, are the services we're providing making a real impact on the individuals we're serving? And in general, there just is no alignment across what data is expected and what the story we're trying to tell is with our community dollars, with our taxpayer dollars. So if we could figure out a way to both harness what we're doing with HIE data, with what we're doing with fiscal data at the state, with what we're requiring to be reported through the RAIs or through the crisis service organizations or any other ASO or publicly funded contract, and bring that together, we get a whole lot more efficient, we get a lot more effective look at what's working, what our public dollars are going towards, and I think that will really drive the transformation and bigger kind of systems level outcomes that we talk about a lot in a lot of different places, but we really haven't unified, I think, in a meaningful way.
You guys have all worked with me for a number of years. Are you okay if I go off script a little bit?
Would expect nothing else.
I think that's you.
So let's talk about Aurora. Let's set Denver aside. I used to serve on a board of an FQHC that serves the Aurora community. I think there's something like 213 languages spoken in the Aurora public health school or public school system. This particular FQHC used to spend $50,000, $60,000, $70,000 a month on medical translation services. In southern Colorado, we have a big migrant farm worker population. We have Native American populations. Can you talk a little bit about what your systems are doing to build on all of the things that you just described, but talk about how you're trying to address cultural competency and equity and accessibility from that lens? I went off script, so you guys can jump on wherever you want.
I can start. So I think, so I practice and I live in Aurora. So this is a community that I'm very familiar with, and exactly what you said, the diversity of languages, the diversity of cultures is awesome. And it's something absolutely to be celebrated. However, it does pose a lot of challenges in terms of staffing up well to meet the community where exactly they are, because you cannot take good care of people if you don't have people who are there taking care of them that look, speak, eat like they do. So one of the programs that we've started is really to bring on diverse, community reflective staff into our hospital to actually be the people who are the caretakers of those individuals that come to us seeking care when they're at their most vulnerable points in time. Many programs that I could speak about for not just recruitment, but also retention of those staff. But for the patients who are coming to us, a few things that are going on. Number one is obviously the screening process. So when a patient comes to us, no matter which door they come through, we're asking them to tell us from their view, what language are they speaking? What language would they prefer us to speak with them? What is their race, ethnicity? What are their needs socially and or financially? Because it's honestly a real question for patients, especially in this day and age where people wonder and think about, is this life-saving treatment going to basically deplete my life savings? So, that's one of the real factors that we have to think about when we are looking at what's the right set of medical treatments or medical workup that we want to do with patients, is asking them about that question, which historically not been a comfortable subject, but our patients are asking and thinking about that now. And so it is on us as healthcare providers to be able to feel comfortable asking those questions, and also drilling down to making it okay, making it a safe place to gather that information. So that screening process is really important. And then being able to turn around and say, okay, I heard that you need these 3 things. Let me get you connected to the resources that you have told me that you might need. So that's a lot of the, I think, meeting the patient where they are is a really important thing that we're trying to do. So in 2 ways, as staff, bringing staff in to be the people who are taking care of them, and then also just asking. I mean, people will tell you what they need and what they are really looking for. They can't always tell you what their diagnosis is, but they can tell you what feels wrong, and they can also tell you what the things that they need that aren't necessarily medical things. So.
It's a really great question, and I'm trying to think how to give a value in a response that adds value to what Dr. Taddy said. I think, you talked about telling your story over and over again, and we have a lot of individuals right now. A kind of flashpoint issue in one of our school districts is whether or not to adopt a policy by the school board to accommodate transgender youth. It is an intense debate in this community, really heartbreaking because, quite frankly, there's a lot of adults yelling at each other in front of the youth who are impacted. But it really makes me think about one of our key values at Solvista is to be a place where all are welcome. This has to be a safe place, physically, psychologically, for all of our staff and all of the people who frequently come to us in what is maybe the most desperate time of their life. And if you take that incredibly courageous step to come in through our door as, for example, a transgender youth and ask for support, say, I am really struggling with this and I just need to talk to somebody, you probably expect to tell your story once and why that is very challenging. But if you then have to retell that story over and over again, whether because maybe we provide some services, maybe we're collaborating with another community partner to provide some services, maybe they have a stay in a hospital because they've made a suicide attempt. They have to re-describe their experience and all of that once again. If there was an opportunity to even just recognize preferred pronouns, to even just recognize some of that story in a shared data place and a shared electronic something, I think that that would have a tremendous impact and reduce the repetitive trauma that that individual is probably experiencing.
Yeah. I mean, I can only speak from the data perspective, being not a clinician and kind of more on the IT side, but I know initially with the RAE data, we weren't getting comprehensive race and ethnicity data on the eligibility file. It was a separate file that then we had to try and bring in and put in our systems so we could do reporting on it. So I think that took some time because it's just not inherently there. It's not something that's constantly updated from the eligibility files. But we were able to do that, and that brings all that data into our care management platform and our customer service platforms that allows those resources to utilize that data. So I think data is key again, even in this situation.
So as we think about, and Melissa said this morning that this may be one of the first times that folks have ventured out kind of post-pandemic, if we are post-pandemic, seems to change on a daily basis. But how has the pandemic changed your view of your work or has impacted the work that you've prioritized or done? And how do you see us kind of moving into the next phase where there's lots of uncertainty in the world, pandemics aside? How are you all viewing kind of, what you learned from the last 2.5 years, maybe improvements that you've put in place, the emergence or the wild adoption of telemedicine and others, and how do you see us kind of moving into a post-pandemic era?
I mean, I'll approach this from a totally different perspective because, again, the nature of IT. We had to move 450 employees home in a matter of a weekend. Mm-hmm. And so I think just the nature of how we do our work as a health plan and how we engage with our members changed significantly. We couldn't send care managers into the homes of our members. And so I think it created a really large gap in our ability to serve our members because of that. So it's really twofold. I think we've had to get innovative. We're kind of out of it now, and we're in this sort of hybrid workforce, which I would assume most of you, at direct patient care, obviously not. But having to shift our entire workforce and our relationship with our members, and really thinking about the member experience and honoring, where the members are at and how they want to engage. That led to us having to set up very different systems than we had previous. And, I think our workforce seems happier in this hybrid environment. Initially, I think there was a lot of thought that work would go down, people wouldn't do as much. We actually found the opposite. And I think it allowed us to better support our members and engage where they want us to engage, given that we had more diversity in how we were set up and how we could connect.
So it's just so funny to get questions about what does it look like post-pandemic and have it still be like this. Are we post-pandemic? Are we not? Because I live in Canyon City, and I don't know if anyone's been to Canyon City, Colorado. It is very different than Denver, Colorado. And as far as we're concerned down there, like we were out of the pandemic in like April of 2020. It was like, all right, we did that. We're past it. What's the new normal? It's exactly the same. Everybody's everywhere with no masks. Anyway, for us as a healthcare organization who we had to continuously remind, we're very highly regulated. We in fact cannot pretend that this isn't happening anymore. We really saw technology as kind of our equalizing force, I guess. We are still now about 40% telehealth services, and that has really helped us to address workforce shortage, to extend new service lines within our own county and our own counties and catchment area, and have a lot greater depth, and also be much better at reaching individuals according to their preferences for care. So I think that's here to stay. I think what we want to do is really create this place where we are uniquely positioned because we understand the entire picture of an individual's needs in a way that some national telehealth company can't just come in and easily substitute. We are the ones who want to have access to unique health information, understanding about the local systems of care that somebody might be involved with, really know the individuals that we serve at a very personal level, and utilize telehealth then as really, again, a force that I think only adds value and isn't seen as kind of a cheap substitute. I do very much worry that the new normal or the post-pandemic kind of healthcare system looks a lot like very large companies across the country. Maybe they're payers, maybe they're providers, we're not totally sure, but they're certainly coming in and doing telehealth in communities across the country. There might be some value for certain types of patients in that world, but again, it cannot be seen as an equivalent to what we can do in local systems of care, really deeply understanding the needs of individuals in our communities.
Yeah, I would agree that post-pandemic, my recognition of what's happened is that people are accessing healthcare in so many more ways and in so many more places, and people are mobile. I mean, I know that regionally people are mobile, they're going to different hospitals, but now people can go to a clinic in a pharmacy to get their, whatever sports, exam for school, right? So that would mean to me that there are many more places for health data to be generated, and they're not all connected. So I guess I would wonder to what degree all of these telehealth visits, like the national telehealth companies, are they interfacing with my health system in terms of the EMR and then our HIE? I have no idea. So I cannot see those telehealth visits that person may have had with a company that actually is in Minnesota, for example. Mm-hmm. So I think post-pandemic, for sure, digital health access is going to stay. Virtual health, telehealth, all of that is going to continue to be a reality because people really, I think, appreciated the convenience of it for some specialties. My husband's a urologist, so like the urologic exam, I think, would be really uncomfortable in a telehealth fashion. But but there are some specialties that are perfect for telehealth visits on an ongoing basis, especially once you've established care with an in-person visit already. So I do think that digital telehealth, virtual health is going to continue to proliferate and grow, and I think more and more patients, as we get to patients who are more technology savvy and more comfortable with interfacing with humans through a digital interface, that will continue to just grow. So that's one thing. I think the other thing is just the recognition that there's a huge reporting burden now, that everybody wants data about everybody and everything. And
just a little bit differently than the other people.
Yes,
right?
Just a little bit differently. And it's like, okay, yes, this is data about a person's heart, but there's 5,000 ways that you could capture that one piece of data depending on how you define that metric. And so we need to do something about the redundancy of collection, the redundancy of reporting, and the specificity, getting all of us on the same page as to how we measure things, because that's the proliferation of the different ways that we measure everything. It seems like the same thing. We're looking at somebody's eye, and it's like 1,000 ways you can measure that. So those would be two major issues that I think we're going to continue to face, and that we'll really need to work out or unravel moving forward, whether it's post pandemic or I guess post pandemic recovery. I don't know where we're at. So.
And you're the doctor.
Yeah, and I'm the doctor.
So as you think about, I'm 100% certain that all three of you have extraordinary to-do lists. But as you think about the thing that really gets you energized and out of bed in the morning, what's like the coolest thing that you're working on right now that you'd want to share today? I'm off script again, just FYI. I'm putting everybody on the spot.
Well, I can, so we just have a new vice president position over our care management program, and her name is Joy, and she came from Maryland. She's worked with CRISP and has all of these exciting ideas on how to use HIE, and I think it's bringing kind of some new energy and passion that I have somebody to partner with who's like, hey, I want to do these things, because they did great things with CRISP. So I think look for some new stuff coming from Colorado Access on, how do we innovate? How do we move the needle? How do we do things differently? So I'm pretty excited about that.
Nice. Well, the ex-CEO of CRISP is somewhere in the back of the room, so
well, I will have to say hi.
Introduction. What's the thing that gets you out of bed in the morning that you're just jazzed about, looking forward to do on your to-do list?
Yes, so I am, I'll just admit it, I think everybody, you probably know this pretty well, but I am kind of a data nerd. But the thing that I'm really excited about, and this is very consistent with something that I've always cared a lot about, which is, so my role as the Associate Chief Medical Officer for Patient Flow at my hospital, it is about throughput and moving patients through their inpatient care journey with us as efficiently and safely as possible. But what that means to me is that we are allowing patients everywhere to have access to us, because the better and more safely and with efficiency that we can help patients through their acute care episode, the better that we can offer outpatient care and access to the specialty services that we have at our hospital. So for me, that is very exciting. And what that has required us to do is, especially in this staffing shortage, healthcare has been one of the hardest hit industries in terms of people moving out of our careers. But our partners in the post-acute care setting have also suffered mightily in this great resignation or people leaving the healthcare industry. But those partnerships, I think, for me, are also really important, because being able to work with our post-acute care partners means that on the front end, our emergency departments and in our clinics, that we can continue to provide access to care for patients at the time that they really need it. And that, to me, is really exciting, because one critical, just going back to the last question, healthcare is a finite and limited and scarce resource, any way you cut it. It is expensive. It is not always easy for people to get to, because there are physical places, and now that we have virtual places for people to get care, nevertheless, it is still a limited and scarce resource. And so the more that we can have people access it in a way that's easy for them to get to, the better that we can keep our communities and family members and friends healthy for longer, so that they don't need to have access. So getting them access at the right time is really important, and as you can tell, I care a lot about that.
Well, I'm a pretty excitable guy, so there's a lot of things that come to mind. I mentioned the crisis facility that we just stood up in Salida, Colorado. It fills this kind of 15,000 square mile donut hole where we have no higher acuity care for behavioral health. That is extremely exciting to have that kind of resource in rural Colorado. Maybe a little bit more connected to kind of this conversation, something that I'm really proud of that we did right as we were in the early stages of the pandemic was go through this entire health innovation collaborative that was sponsored by the Colorado Health Foundation and really focused on human-centered design. And we've sent multiple cohorts of our staff through through human-centered design training. So working deeply with the individuals who may be impacted by a challenge or are really the end users on deeply understanding how we can design better solutions, how we can implement those solutions, test them, improve upon them, increase throughput essentially, but really come up with solutions that we kind of have shared ownership of the problem and then sharing the design and implementation of the solutions. One of the pieces that we did as a result of going through that training was create a digital front door to care, which for a behavioral health organization in rural Colorado that most definitely does have finite resources and scarcity was really proud accomplishment for us to be able to kind of put this cool piece of technology out there where for a system that has notoriously onerous, uncomfortable kind of intake processes, community mental health is not always seen as like this really warmly, easily accessed service because there's so much paperwork and stuff you have to do. Creating a digital platform where somebody could just do it from their smartphone, have the first questions be focused around how can we help you? What are your needs rather than what's your insurance and can you fill out these 5 pages of demographic information so we can check boxes? That felt really good to be able to roll that out. And it's been really successful, almost too much because of our scarcity issue. We're like, do we need to slow this down because we're going to have too many people coming in and maybe not enough workforce to serve all of those individuals. But at the end of the day, it's a really cool evolution on a system that when I say system, community behavioral health kind of nationally, a system that I think is desperate for some evolution. So it was nice to kind of have that win.
Great. Well, so we have about 15 minutes. And I want to make sure that I can't see, I'm behind the podium over here. 6 minutes? No, 6 questions. Oh, 6 questions. All right, so let's get some questions going. And if you're in the room and you want to step up to a mic, please don't be shy. One second. Hold, please.
So the first question is, I am interested in hearing more about permissions from data sharing regarding mental data that Morgan mentioned and Brian alluded to the need of.
Sounds like we have a character limit problem on our platform.
Tweeting their questions.
Well, I can certainly give the HIE perspective, and of course we've got a bunch of colleagues that are going to come up here in a little bit and talk about the national perspective. But historically, I would say that there have been 2 barriers to behavioral health information exchange actually happening in Colorado. I would fully anticipate Brian to agree or disagree with me. One has been something that seems fairly simple, but has been a really big challenge, and that is a common adoption of those forms that we use when you walk into the healthcare setting to say, I am consenting to a common process for data sharing. If we don't have consistency for that very seemingly minute process, then we get conflicts in the way that we can actually exchange data. If I walk into Brian's system and I'm the patient and I say, well, I only want my data shared with this particular provider at this particular system, but then I walk into the behavioral health system down the street and they have what's called a general designation, which says, I want all of my healthcare provider team to be able to access my behavioral health data. You get these conflicts in the system that create very, very challenging technological barriers at scale. So the first thing that I would say is just generally agreeing on an acceptable consent mechanism and even form that we use at check-in that we can kind of normalize the consent system across all of these different settings. The second one is that there have been kind of, I'm going to call this imminent changes coming from SAMHSA with regard to 42 CFR Part 2. And so, you know, in my space, I'm always looking at, can we build this thing and future-proof it? And it's really hard to future-proof things when there's always imminent change that seemingly never comes. And so I think that there's been a little bit of a wait-and-see approach to see what SAMHSA comes out and says with regard to amending 42 CFR Part 2. But those are kind of the 2 big barriers that I would say. How about you?
Well, I completely agree with you on the consent management side. The inconsistency and the number of lawyers with different opinions about how you need to cover your ass is absurd. And it hasn't changed. It's like we have recycled that conversation literally for 10 years, if not more. And so it does not seem like it should be this difficult, but it has proven to be very difficult. And I know there's been also progress, Attorney General's office, and kind of having like, hey, give us the blessing that we can then carry to our attorneys, our legal teams, and see if that makes people a little less jumpy. The part where I might not disagree, but you mentioned 42 CFR Part 2 earlier, and I think you called it antiquated, right? And I would agree. We have been waiting for updates to it forever. But I also don't want to disregard why it does exist, right? It is absolutely born from a very, very important and good intention. And going from the policy world where I was before, I would frequently be like, this is stupid. Why don't we just get rid of that? It won't be an issue anymore. And then getting to more of the front lines of care and seeing how individuals have absolutely been discriminated against because they have a substance use disorder. We have to have a meaningful protection there, and I understand why it exists. And I kind of hold my breath to see how revolutionary any changes to it might end up being, which brings me back to the importance of just having more consistency on the consent management side too. So I think it's due to be evolved. There's probably some protections that we need to just honor and understand are really important until we move the dial even farther in the country when it comes to stigma and discrimination related to behavioral health issues. Focus on consent management is the highest priority for me.
And I do think that, and again, I'll harken back to my rural health days, I do think that when you are talking about communities that are very small, communities that are tight-knit, it was not uncommon that the behavioral health provider in my clinic was the neighbor or, the wife's best friend of the patient sitting in front of me. And so I absolutely agree that, safeguarding and building trust in this policy and framework is critical to making it work right. There are very real scenarios, particularly in rural communities, but in all communities, where that data, if not used in the right way and in a trusted environment, can have really, really detrimental impacts. And being discriminated against is one, but in rural communities, there are a multitude of other scenarios where sensitive information really becomes more and more sensitive because the communities are so small.
Yeah, and it ties back to the importance of things that we have in this state related to practice transformation, related to integrated care, because one of the ways you can prevent that misuse of the data is by having deep understanding, deliberate training and transformation efforts in all of the healthcare space on behavioral health issues, right? So I think there is absolutely a path forward. We've just got a lot of steps that need to unfold.
Morgan and Brian, can I just add? I think that the stigma that you're describing on behavioral health data and a patient's behavioral health history, I think is going to be the same kind of challenge that we may face going forward with SDOH data. I think especially, my experience has been that even just asking about what's your primary language, patients sometimes do not want to disclose that English is not their first language or even their second language. So just, I think, for us to be conscientious as we move forward in thinking about that, what new stigma are we going to introduce or amplify as we begin to really double down on collecting this data?
Absolutely. It's a quiet audience today. You're all texting your questions.
The next one is the information from Colorado Access is usually claimed based and more than 9 months old. It's not usable for the providers. If providers can't afford Contexture, what is the solution?
Yeah, so we've initiated some projects around provider data, sending provider data. In some respects, the claims data on the physical health side is what we get from the state, so that's the tough part. On the behavioral health side, obviously, we pay the behavioral health claims, so that data is going to be more timely. Whoever that was, come see me after this, and I'd like to understand more, get you connected with our provider services department. Internally, we've done a couple of different programs to enhance our partnership with our providers. Obviously, that's, the providers are important in making sure our members get the services they need, so we want to make sure that we're supporting the providers both in payment and in data. So yeah, reach out to me after this and we can have a conversation. Thank you for pointing that out. It is something that we've been working on.
Do you have any plans to get payers to communicate when it comes to quality of care in HIE?
That's a question for the moderator? She's throwing me off script. Do we have any plans to have payers participate? Well, so, in Colorado, we are very lucky to have probably one of the most robust APCDs in the country, Civic with the all-payer claims database. Civic, has probably 60 to 70% of all paid claims flowing through the APC at this point. We have, for a long time, worked very closely with Civic to try and figure out ways to use the technology across both of our platforms to either integrate, to the earlier question, to augment the claims data that people may be getting for ACO purposes or others. Ironically, in Arizona, we actually provide APCD-like services to the state Medicaid agency. Some of the COVID dashboards and some of the bed registries that I showed you earlier are actually powered by state Medicaid claims information. And so as we venture into that space and become more familiar with claims, we will absolutely be looking to, and you saw it on the strategic plan, integrate more and different types of data, which would include payment data and claims data, because we know that the HIE isn't 100% of what happens in the healthcare space. We also know that that not 100% of what happens in the healthcare space is necessarily paid for by a payer that has to submit their information to an APCD or an APCD-like organization. So absolutely, we do see that the integration of claims and clinical information along with social determinants of health and advanced directives is kind of the golden ticket to having that comprehensive view. And I do think that we'll continue to plot down that path that is in our strategic plan, and constantly trying to work to solve the problems of getting the right information at the right level of detail, in the right level of succinctness, in the workflow when it's needed by the right person with the right consent model. Absolutely. I mean, that's what gets me out of bed in the morning.
What I didn't hear you mention is care plan data. And I think there's a multitude of care plans for a single member. So add that to your list. Let's do some care plan exchange. I think they're doing that in Maryland, so yay to Maryland.
Is there a plan for a patient portal to enable patients to see and validate the data that is attributed to them?
You want to talk about open notes and all of the work that UCHealth is doing in that space? And
yeah, so I can speak a little bit to that. So at this point, I don't know about many, but some EMRs are giving patients access through a patient portal to their electronic health record. And I don't know that there's validation functionality built into that interface at the moment, but at my organization where I practice at University of Colorado Hospital, we have given patients access through this initiative or this program called Open Notes, where patients are actually able to see their providers' progress notes, history and physical notes, the notes that their physicians and advanced practice providers have written about them, in addition to some of their test results, including radiology or lab results, pathology results. I think one thing to, and so for example, my dad's actually in the hospital right now in Chicago. I won't say which one, but he's in the hospital with heart failure. He had a pretty complex test done, a right heart catheterization, and So of course, this appeared in his medical record through the patient portal, and he's like, I don't understand what this gibberish is. And I looked, and it was the requisition information for the exam, and it was the timing of it, the codes for the exam. And I said, well, that's not the information you need to know. Scroll down to the results. And he's like, is that in English? And I was like, well, yes, it's in medical English. But that's one of the challenges with giving patients data to the primary or the original source health information is it's written, I guess it's similar to when I'm looking at like legal documents. This is all written in legalese, and I can't make sense of what this is trying to explain to me. So for me, one of the things that I've learned in that initiative is that releasing some results needs to be paired with a conversation with a provider who can help a patient make sense of that data, make that data informative in their view and in their perspective. So I don't know what the plans are for the HIE to create a patient portal, but that's one of the things that we've been working on at my organization.
And I'll address it from two different angles. So earlier you saw the Arizona Advanced Directives Registry. That's really the first time that that Contexture is actually facilitating a patient-level conversation and facilitating the exchange of information directly from the patient as a source. It's a wildly new frontier from where we've been, considering that our entire history is built around that provider and healthcare organization relationship. And we also have some imminent federal policy coming at us that hopefully some of my colleagues will talk about later. TEFCA, the Trusted Exchange Framework and Common Agreement that Melissa briefly raised earlier, it does have requirements in it that they're describing as individual access services. And so you can imagine, and Jay Nakashima is actually in the audience today from the eHealth Exchange. He is probably the foremost expert on everything TEFCA in this room. But the ONC and the federal government are absolutely pushing all of us and these systems towards creating greater transparency and accessibility for patients. And so I definitely see a federal policy coming at us. Info blocking from CMS is another rule that's going to play into that space. Where we fit into that, I don't know that that's defined today. We somewhat get a mixed bag of opinions when we talk to our stakeholders about what role we should play in that patient access relationship. To Dr. Taddy's point, Contexture is probably highly unknown or invisible to the majority of patients in Colorado and Arizona, and we really want to make sure that everything that we're doing behind the scenes is empowering and improving that relationship between the providers and the patients. That is a changing landscape at this point, and so it's a little unknown where we will go from here. We'll certainly always work to meet and abide by federal policy, obviously, but it is a changing landscape. And I think that we're going to run into all of the complications that Dr. Taddy just described. And directly out of the other side of my mouth, I would love for the nurse at my kid's school to not have to pester me when it's time to get those annual well child visits. If they had a way, if I had a way to bring that from my provider's office in an easier way than going and signing for it at the front desk and then carrying that piece of paper over to the school, that would certainly make certain components of my life easier. But there's a big difference between a right hearth catheter and a well child exam.
How do we get EHRs engaged as partners in the efforts to increase value and expand data sharing and interoperability? What is your experience?
You run EHRs every day. I mean, I have a biased opinion. I work in an EHR every day, and there's a lot of benefit for the patients who are, and the information that's contained within my EHR. It's great. I have great access to, so if a patient has a record within my EHR, even if it's in a different state, I can access it.
The challenge becomes when I have a patient who has care providers or seeks care in facilities from multiple different systems that are on multiple different EHRs. So for me, it would be the benefit of our HIE is that it is providing me information across EHRs, across systems, specifically for the benefit of that patient so that I can actually see, not specifically care plans just yet, but when you get there, I will have better access to that kind of information. But for right now, that context is incredibly helpful. So do I wish there were more? Yes. Do I think that the HIE today is filling some of that gap? Yes.
For our EHR, behavioral health EHR, it is the biggest driver of staff unhappiness of anything else that we have, right? And it's because the EHR is built around the organization complying with the needs of our funders, those who regulate us or those who are giving us dollars, so that we can check a lot of boxes and then demonstrate compliance in an absurd, huge number of ways. It's not around empowering the individual provider to have better information to drive clinical decision making. It's certainly not designed around giving the patient or the client, the individual receiving that care, a greater sense of what their treatment plan looks like and decision making and all of those sorts of pieces. There's some good progress being made. I think the next generation of electronic health records in the behavioral health space are going to have a greater emphasis on real utility from a clinical perspective rather than just checking boxes. But for now, that's kind of where we are. So to answer the question, there's huge opportunity to drive a whole lot more value, improved provider and patient experience, information exchange that has value in all the ways we've been talking about, in partnering and really working through electronic health records. But at least in our world, it's far from it today.
And I would go back to the policy perspective, and I'm looking at Jamie and John and Jess. Maybe that's something you can talk about a little later, but certainly one of the intent, an intent of both the info blocking rule and TEFCA is to address directly that. It's to try to break down the barriers that have been built by some real and some not, both the technology and the cost barriers that go along with EHRs to standardize how you can charge or how you can interface with those EHRs. There was an interoperability component of the Meaningful Use Certification program, but it was kind of a scattershot when you looked at how EHRs were complying vendor to vendor and sometimes even version to version. So absolutely one of the intents of both the info blocking rule and TEFCA is to break down those barriers to integration and data sharing and interoperability. That's kind of the standard bearer government response to these challenges is to push a policy at it. But certainly, and today there are no sticks. There are also no real carrots. But I would assume that before too long we'll see more sticks than carrots to creating barriers to interoperability and data sharing.
I've got the final question. Okay, hopefully this mic is going to work now. I'm really excited about everybody sending in their questions, so thank you. And glad that's working. I did have a question to kind of pull together on a couple threads that you all have mentioned. We talked about the provider and the administrative burden of, yes, we need all this data, but it's coming in huge fire hoses and it's hard to digest. We've talked about the EHR is not every provider's best friend, but yet we acknowledge that we need the information. And then we also talked about the patient and the individual burden on being assessed regularly on whether it's social determinants, whether it's family and medical history, but yet some of those things change over time. I think where we're going, and one of the things we have to focus on, all of us collectively, is how we curate the data and how we present it in ways that's meaningful. So I was curious, just as a wrap-up question, either do you all have examples of where data curation has worked well within your organization, where you do have this mountain of data and you found good ways to surface up what you need in that instance? Or do you have ideas about how, as an HIE, Contexture can help support that. We've got examples of where we've done that intermittently, but it's that balance between, everybody wants their report a little bit differently, and so that takes customization every time, but also finding those sweet spots where we can solve that data curation challenge. To stump the entire panel with the last question.
I think from an actionable data perspective, having alerts that have workflow, you're not gonna hit it with a shotgun, right? This is gonna be very specific things that you're gonna do something with and have an outcome. And I think if the more of those things you can have that have a specific action, have an outcome that you can measure, I think that's going to be beneficial. But you also do have to sort of do that shotgun, right? When you're looking at retrospective reporting or outcomes analysis where you can utilize the data to do baselines. You never know what you're going to want to do in the future, so it's great to have all of that data there so you can go back and look at sort of historical baselines and then do prospective analysis on interventions or those kind of programs. So I think that's probably where we've seen the highest value from, the Colorado Access perspective. I think you two probably have very different perspectives.
Go ahead.
So I think for me, probably the best example of data curation that I can provide is when we were taking care of really sick patients, our clinicians relied on calculators, risk calculators, for patients who are really sick to help us understand what this person's morbidity or mortality risk may be, so that we could think about which treatments may or not providing treatments that may push them over the edge for whatever reason in terms of morbidity and mortality. That kind of data curation starts to wander into the realm of prescriptive data analytics. It helps us make decisions about what to do next for the benefit of that patient, taking into consideration all of this other data and factors that I might not have time to go and look for or to uncover from all of these different sources, and then basically serves up a set of options for me to do. Now, does that shortcut my thinking process? Yes, to some degree, because it prevents me from having to go and look at the mountain of data that might be out there. Is there some risk in doing that? Probably yes. Anytime you're beginning to curate data, you're right, Melissa, every person is going to want something different. Your rheumatologist is going to want different information than your cardiologist, than your hospital radiology technician. And so I think that's I would say the caution that we would need to take as we begin to curate these different perspectives.
I think I'll just kind of focus on an opportunity, I think, for better curation of data that could really have an impact. Community behavioral health centers and all behavioral health providers, I would say, to build on this theme of kind of fragmented reporting, maybe an inability to even demonstrate a consistent set of outcomes, organization to organization. Maybe that's because of state agencies dictating different things, maybe it's not, but if there's a way we can position health information exchange to support certified community behavioral health clinic initiative at the national level, right? So delivering on the Community Mental Health Center Act that Kennedy put forward that actually creates a true system of mental health centers that are all reporting on a consistent set of data to demonstrate accountability and real behavioral health and kind of integrated health indicator outcomes. We can kind of get past this debate about how broken is our behavioral health system in this country and actually say, here's what it's doing, and we all agree on these performance measures, and that will then help us drive policy changes. That'll help us drive continuous quality improvement efforts at the local level and at the RAE level and at whatever other level we need to. If we can leverage the power that our HIEs have to be kind of a central source for collecting that information, giving it credibility because it's kind of an independent arbitrator of that data, I think that's a huge opportunity and a big reason I continue to infiltrate Contexture.
All right, well, thank you all of you for your long-standing support for Contexture, for agreeing to sit up here and let me throw curveballs at you early in the morning. And please, if you have more questions or just want to touch base with these folks, they'll be around, and let's give them a big hand.
To our HIE Excellence Awards. Okay, let's see. So we are really excited for the inaugural year in Colorado to present the 2022 Colorado HIE Excellence Awards. As I mentioned earlier, these awards are to recognize one individual and one organization that has really advanced health information technology and health information exchange in their work, in their organization, and all the things they participate in the community. So first, we're going to start off with the HIE Excellence Leader Award. This is an award that recognizes an outstanding individual whose leadership has helped advance healthcare through health information technology and health information exchange. I am pleased to announce that the recipient of this year's Colorado HIE Excellence Leader Award is Michael Jeffries. I'm going to read a little bit about why Michael is so deserving of this award, and he's not able to join us today, but he did provide us with some remarks via an acceptance letter, so we're going to have one of our team members, one of our key Contexture leaders, Deanna Town, come up and read that in a second. So Michael's being recognized for his outstanding leadership in helping to advance healthcare through health IT and HIE across Colorado. With over 20 years of experience in health information technology, Michael's passionate about implementing solutions that evolve patient and clinician capabilities in pursuit of better well-being. He joined Boulder Community Hospital in 2016 and has implemented technological advancements across various settings, including acute care hospitals, physician clinics, post-acute care, home health agencies, surgical centers, emergency departments, and inpatients' homes. Also, Boulder Community Hospital was the first hospital in Colorado to connect to our HIE. During his time at Boulder, Michael has further advanced the hospital's use of Contexture HIE services, including utilization of Patient Care 360, otherwise known as PC 360, by hospital employees, sending data to the HIE for access by community providers, and we're currently working with him and his team on compliance with the hospital transformation program. He's active in public policy advocacy that promotes the use of technology in healthcare to serve the most vulnerable populations. He's especially passionate about creating a just healthcare system that uses data and informatics to guide the deployment of effective, individualized, and population-based health programs. He's a fellow of the American College of Healthcare Executives and the Health Information Management Systems Society. He's chairman of the Colorado CIO Communication Collaborative, otherwise known as C4, and holds designation of Certified Healthcare CIO from CHIME and a certification as a project management professional. In 2021, he was the nonprofit public sector winner of the 2021 Colorado CIO of the Year Orby Awards. So please again join me in congratulating Michael, and accepting this award on his behalf is Deanna Town of Contexture.
Melissa. Definitely very honored to be able to read this on behalf of Mike Jeffries, and very grateful for the opportunity to work with him on a regular basis. So from Mike, thank you for this great honor, which I gratefully accept on behalf of Boulder Community Health and the network of healthcare leaders in Colorado that make our great state a leader in health information exchange. Patient information must first and foremost remain the property of the patient. It ensures that patients receive the best care wherever they choose to go, to be informed and to be active in directing their care. Healthcare providers require records of the care they give, but those records should never be hoarded for strategic advantage. Although healthcare in Colorado is fiercely competitive, I am grateful to know that our healthcare organizations always put patients first and are committed to the open exchange of records. Many people are unaware of how advanced our healthcare ecosystem has become in Colorado. When you stack up all of the HIM Stage 7 and most Wired awards in Colorado, it becomes clear that Colorado is special, with an intense concentration of advanced technology adoption and HIE capabilities. This advancement can be attributed to the great collaboration among our organizations. About 15 years ago, the CIOs in the state, led by Russ Branzel, had the foresight to establish the Colorado CIO Communications Collaborative, better known as C4. This group was established to act as the guiding body for health information exchange in Colorado and to freely share ideas among CIOs. While I am currently carrying the torch to ensure the C4 tradition continues, I'm just the most recent in a line of caretakers, including Russ Branzel, Mary Ann Leach, Greg Veltri, and Gary Hall. While our organizations compete to attract patients and have the best quality care, we also freely share ideas and advice with each other to improve our capabilities. I cannot emphasize enough how rare and important this collaboration is. Health information is, by definition, a team sport. The relationship between C4 and Creo has been crucial to the advancement of HIE in our state. Creo, and now Contexture, are active partners in helping us achieve our goals as healthcare providers. Without that provider HIE partnership, we would not be in the great position we are today with HIE in Colorado. Thank you for this recognition and the service that you all do to ensure that patients in our communities receive the best care possible. Michael Jeffries.
And we're gonna deliver Michael's award and make sure that he gets it here in the next week or so. All right, so up next, we've got the 2022 Colorado HIE Excellence Organization Award. This award honors an organization for outstanding innovation and achievement in advancing health care through health IT and health information exchange. And I'm pleased to announce that the recipient of this year's HIE Excellence Organization Award is Kids First Healthcare. I'm going to read to you a little bit about Kids First Healthcare, and then again, we have so many in-person events these days. There was a competing conference, so the Kids First Healthcare team is at a different conference today, and we will have a team member from Contexture join us on the stage to share a little bit of feedback. So Kids First Healthcare is recognized for its efforts in utilizing the HIE in Colorado to deliver better care for underserved students in school clinics and to simplify quality reporting. For more than 40 years, Kids First Healthcare has brought low-cost, high-quality pediatric healthcare straight to schools across Colorado to reach children who need its services most. The nonprofit runs 2 community-based health centers and 6 school-based health centers in Adams County and serves about 4,000 children annually. The middle schools are each staffed by a nurse practitioner and medical assistant. The high school staff also includes health educators and medical front desk staff. The majority of patients are covered by Medicaid or CHIP Plus, while 17% are uninsured. Kids First Healthcare joined Contexture in 2015 and relies on the HIE to access patient records, generate continuity of care documents, and to make sure immunizations are included in students' medical records. Kids First ensures coordination among all members of the care team, even providers outside of the school-based health center. They're truly leaders in our community for improving care and health equity. Please join me in congratulating Kids First Healthcare as recipients of Contexture's Colorado HIE Excellence Organization Award. And please join me in welcoming Lauren Gerard of Contexture, who is going to share a few thoughts on the work we have done with Kids First and their significant work in this area.
Thank you. I'm so excited to be able to share this award for Kids First Healthcare. They have relied on HIE services to help submit their electronic clinical quality measures, or ECQMs, for the Medicaid APM program over the last 3 years. One comment from their Assistant Medical Director, Catherine Schruger, speaks volumes to collaborative work we have advanced together. Being a very small organization without a dedicated IT staff makes it difficult for us to work within the EHR for all the deliverables we need to meet. Colorado HIE supports a lot of the back-end work, and we chime in when needed. Without Contexture, we could not do this work at the same level. Thank you again for this wonderful recognition for Kids First Healthcare.
Okay, and you're probably all out there wondering how you could be recognized with this award next year. So I want to make sure that everybody knows some of the ways that we collect a lot of the success stories that we have at Contexture. Our work is only successful when your organizations are successful in utilizing technology and information exchange to advance better care and better coordinated care for all the populations you serve. So we really value documenting and spreading all the success stories that we have throughout our communities. So we do have a case study section on the Contexture website. I think you saw a link to it in one of the slides I presented this morning. So if your organization is doing great things with HIE data and services, we really do want to hear about it. You can talk to your sales manager at Contexture and really learn how to submit a success story. And one of the things we have done in the past to really entice, we know it takes time to share your successes, but it's really beneficial for you, for other organizations like you, and for the community at large. So another enticement is that going forward, when your organization submits a success story, you will be automatically nominated for next year's HIE Excellence Organization Award. And you can go read more about Kids First Healthcare because they are one of the organizations that was highlighted through our success story. So please go to our website, submit a success story, talk to your sales manager about the process for doing that, and this could be you standing on stage, not presenting the awards, but coming up and receiving one. So thank you again for our panel this morning, for all of our speakers.